That is what we do with the molecular data. And I mentioned this during the meeting, and I'll say it again now. We have to agree as a group that if we think certain molecular lesions are inherently targetable, and again, the very specific example that came up in the meeting were ABL1 rearrangements, that as a group, we need to say that this is a group that should have access to drugs that target ABL1. And so I'll give you a good example. The same example that I provided during the meeting earlier today. We had a young woman with a NUP ABL fusion where we requested Sprycel when she failed to clear her residual disease, and the request was denied. And in fact, she was never able to clear her residual disease. We got her down to about 0.07%, 0.1% in that range with intensive chemotherapy, including asparaginase, before we finally gave up and went to blinatumomab. This is a situation, while I can't promise that it would have been avoidable, there was the potential that we could have pushed that residual disease lower using an agent that we know has biological activity in multiple preclinical studies, but also in the case of some clinical studies which are ongoing and evolving. So I would make an argument that that's also something powerful that could come out of this meeting if there is a consensus statement as it relates to the role of the identification of particular mutations and the impact of specific agents in that context.